Welcome, Interlear members. I am Pat Cook, Senior Consultant and Client Experience Professional with the consulting firm Courtemanche Associates. We recently became a strategic partner with Interlear and had the great privilege of presenting the latest information on accreditation at the Elevate 2018 Interlear Conference. Today, we would like to share some of the highlights of that presentation. Some of our objectives today are that we will be spending some time talking about the Joint Commission SAFER Matrix, exploring the complex scoring system used by Joint Commission and how that transfers to or does not transfer to CMS and the conditions of participation. Then we will review the top scoring standards, and I will share some strategies to reduce risk of deficiencies in your organization related to those. And then lastly, we will review the various survey outcomes and what they mean to you. So let's get started. The SAFER Matrix. The SAFER Matrix was developed and introduced by the Joint Commission in 2017. It is designed to aid leaders in identifying those areas within their organization that are creating the greatest risk for the organization, and help organizations then prioritize their improvement activities. The SAFER Matrix was introduced at the same time as CMS and the federal government were concerned around the disparity rates between accrediting agency survey findings and state agency validation survey findings conducted on behalf of CMS. At the time, the disparity rate ranged from 25 to 47%, meaning state agency findings were 25 to 40% more than the accrediting agency survey. As a result, the See It, Cite It method was implemented by the Joint Commission. See It, Cite It requires surveyors to cite every deficiency they see. As a result, the number of survey findings rose from an average of about 18 to 20 requirements for improvement to now an average of 25 to 35, with some organizations receiving greater than 75 deficiencies or requirements for improvement. Pictured here is a SAFER matrix for a hospital survey during first quarter 2017. As you can see from the diagram, the SAFER matrix will plot the likelihood of patient harm or visitor or staff harm across the scope of the issue. So is the scope limited, patterned, or widespread? And is the likelihood of harm low, moderate, or high? And of course, we're going to spend some time later on talking about that dark brown, dark red bar that runs across the top of the matrix that is the immediate threat to life situation. What do we know about the SAFER matrix now that we have a little over a year's experience with it? We know that the majority of findings are plotting in the lower risk, limited scope areas. Majority of high risk, widespread findings are appearing in the following chapters: environment of care, leadership, infection prevention and control, and national patient safety goal related to suicide prevention. It's important to note that the SAFER matrix does not predict condition level findings. Condition level findings are CMS condition of participation compliance findings in organizations that use their accrediting organization for deemed status with CMS. Condition level findings continue to rise, particularly in the areas of infection control. Condition level findings are occurring much more frequently than in years past. Some of that is attributed to CMS's intense focus on quality and patient safety issues in healthcare organizations. So be prepared within your organization to have more condition level findings. Looking at 2017, the Joint Commission published their top 10 problematic standards data twice per year. They are the only accrediting organization to do so. We believe that the trends identified by the Joint Commission are also reflective of the performance of other accrediting organizations alike. The next segment of our time together today will be spent looking at and understanding those problematic standards by accreditation type, and then focusing in on the common threads across all accreditation programs. But first, let's talk about the three most problematic areas that are resulting in findings of immediate threat to health and safety. From data collected throughout the past 18 months or so, three key areas have been identified: ligature and suicide risks, and this is the #1 scoring category within the hospital accreditation, behavioral health, and critical access accreditation programs with Joint Commission. Those findings are scoring in 5 chapters: the accreditation participation requirements, leadership, environment of care, human resources, national patient safety goals, and provision of care. The next immediate threat to health and safety area that has been identified is related to high-level disinfection and sterilization, and this is common across all of the accreditation programs. These findings score in infection control, leadership, and environment of care. And these findings, interestingly, are typically found outside of the central sterile processing department. So in those locations that are conducting their own high-level disinfection and sterilization, perhaps it's an off-campus ambulatory location, a rehab department, a wound center, that's where those findings are primarily coming from. And when you look at the fact that the Joint Commission and CMS are very focused on zero harm and hospital-acquired infections and the cost of that associated with those infections, that's where this is really taken on its focus. The third area that often causes immediate threat to health and safety findings are basic infection prevention practices. Here, we're talking about basic items such as hand hygiene, basic disinfection of surfaces between patients, the proper wearing of personal protective equipment and the selection of proper personal protective equipment, and other findings such as just general uncleanliness in the organization. So let's spend a few minutes looking at those top scoring standards by accreditation program. Keep in mind, this data is from the last half of 2017. The top 10 for hospitals, 4 of the 10 are related to fire safety. Here, we find findings related to fire egress, hallway clutter, to firefighting equipment and fire detecting equipment maintenance. 2 of the 10 are related to infection prevention or infection control strategies and making certain that there's a robust plan for infection prevention and that that plan is implemented and adhered to. And then last but not least, EC 020601, which is the standard across all accreditation programs that talks about needing to have a safe and functional environment. This is where in 2017-2018, unsafe conditions related to ligature risks have been being scored. Continuing with the same themes, critical access hospitals' problematic areas nearly replicate hospitals. Here, 6 of the 10 are fire safety related. 2 of 10 are utility system related. 1 is related to infection prevention and control, and 1 is related to medical gas vacuum system management. Next on our list is behavioral health. Behavioral health has a unique pattern. Only 1 of 10 are related to fire safety, but 4 of 10 are human resource related. Here we find findings related to staff qualifications, competency assessments, and flu vaccination programs. Of the 4 of 10, the remaining 4 of 10 are related to patient assessments and patient screenings. The next focus area would be the Ambulatory Care Accreditation Program. Here in 2017, these findings are based upon 695 surveys. The Ambulatory Care Program, again, has different trends. Medication management accounts for 2 of the 10 top problematic standards, and 2 of the 10 are infection prevention related. Again, if you're thinking about the slides, we're seeing a very common thread around infection prevention. Last but never least, the nursing care centers, previously known as long-term care. This data, again, is based upon 320 surveys that were conducted in 2017. This reflects a true cross-section of findings. Here we find findings related to assessment and reassessment, to care planning, to medication storage, and basic infection prevention again. And EC 020601 regarding safe and functional environment is a very high scoring standard within the nursing care centers because, again, we're dealing with patients who are elderly and potentially have dementia or Alzheimer's, and so we have to make certain we have a safe and functional environment for those patients. So looking back, please note that there are 3 common threads amongst the majority of the accreditation programs. Here, the 3 common scoring areas in 2017 are the risk of infection associated with medical equipment, devices, and supplies, which again could potentially score as an immediate threat to health and safety. Maintenance and inspection of utility systems and fire systems, again, can score as an immediate threat to health and safety. And last but not least, safe and functional environment, which will also score as an immediate threat to health and safety. Please note that all of these 3 topics align with CMS findings. So let's spend the next segment of this presentation talking about these 3 common threads and some strategies to improve your performance related to them. Cleaning processes and practices have everything to do with instructions for use. So when we're talking about infection prevention practices, making certain that staff understand the instructions for use associated with both the cleaning product and or the equipment is essential. Unfortunately, many of our processes are designed to rely on staff memory. What do I mean by that? Well, the package inserts are usually not kept with the equipment and are typically not stored with the cleaning product. So we will teach staff, we'll provide an educational program, and rely on staff to remember that the red-topped container is to be used on this equipment, and the blue-topped container or spray is to be used on a different list of equipment. And that can be very complicated and difficult for staff to remember. We also tend to make too many disinfecting products available or too many cleaning products available. Here are some of our recommendations. First and foremost, make certain that you have a group that reads through the instructions for use or operator's manuals for each piece of equipment to determine what the cleaning requirements are for that piece of equipment. Keep in mind that bleach products very often are incompatible with any item that may have a computer display screen. So that's an area to focus in on. What we would encourage you to do is create cheat sheets or posters for staff to refer to. By doing this, we can avoid staff from having to rely on what they remember. Streamline your inventory of products with infection control oversight. It's really important that you partner with your infection prevention team to make certain that the products you're selecting are applicable to the organization and are providing the amount of coverage that is needed based upon the organization's microbiology data. Last but not least, perform walking rounds to query staff on processes, and then perform silent observations to see how staff actually apply the practice. High-level disinfection. While we were talking about infection prevention and control processes, let's spend a few minutes talking about high-level disinfection. This is a huge focus and a huge risk to patients. There's been numerous media events in the past years. Many of you may remember probably about 5 years ago, the endoscope cleaning process, the exposure to hepatitis that has been reported, mad cow disease that has been spread through brain surgery and improperly cleaned equipment, and I could go on to name several other media events in the past years. High-level disinfection and sterilization is extremely complex. The processes are based upon available sterilization equipment and the medical equipment that is being cleaned. Here, our recommendation would be make certain, first and foremost, develop an inventory. Know where reusable instruments are being used within your organization. Make certain that you query all of your off-campus and ambulatory care locations, as oftentimes they get missed. Make copies of the instructions for use and make those copies readily available to staff. Put them in a binder, laminate them, make certain that that information is available to the staff. And do not be afraid of using signage to help staff. This can really encourage your staff to do things correctly. It puts the knowledge at their fingertips and, again, does not have them relying on their memory. High-level disinfection and sterilization also requires intense monitoring or strict monitoring of your air pressure relationships. So make certain that you're working with your facilities management team to make certain you have a robust process to capture that information. And most importantly, that when those air pressure relationships are not aligned properly, that you're taking immediate action to realign the pressure relationships and or stop the line or the disinfection process or sterilization process while the air pressure relationship is being rebalanced. Review your policies and procedures. Your surveyors, whether they are CMS, state, or accreditation organization surveyors, will review your policies and procedures anytime they believe that there may be a misstep by staff. So make certain that your policies and procedures clearly reflect what the expectations are. And then last but not least, educate your staff every month and observe their performance. The second topic that we wanted to talk about is related to utility systems and fire systems. Again, a common thread in all of the accreditation programs. Utility system and fire system maintenance is an extremely complex system. The inspection and testing processes are very intense and very time-oriented. Please make certain that your schedule aligns with the manufacturer's instructions for how the system should be being tested and that your testing frequency aligns with that recommended by the manufacturer. One of the complicating factors when we look at utility systems and fire systems is oftentimes the maintenance of these systems is outsourced to another vendor or provider. This makes it a little more complicated to make certain that you have all the reports that you need, that you get them back in a timely manner, and that those reports are addressed within your organization. Please note that missing reports this year are an automatic requirement for improvement. Joint Commission in 2018 published a new list of required documents for the Environment of Care Life Safety Surveyor to review. And these reports and inspection reports are all included on that required documentation list. Deviations from the inspection frequency will also result in requirements for improvement. Continuing with our compliance strategies, We highly encourage organizations to have a process where you review every inspection and testing record. Make certain that you address every negative comment and include a timeline for correction and outcome. It's not uncommon for one of these outside vendors to perhaps make a recommendation that the filter may not need to be changed today, but perhaps it should be changed in the next 30 days. That may get noted on a report, and if we don't go back and complete that work and have documentation showing that we completed it in the 30 days, that can result in a requirement for improvement for failure to maintain the equipment. And of course, keep your documents organized. The better organized they are, the more the surveyors will understand that the organization isn't just collecting these reports, but they're actually doing information and using them to improve the delivery of services within their organization. The last area, which is our last common thread, is again bringing us back to the safe and functional environment standard. This is frequently scored in all programs. We often refer to this as a catch-all standard. One of the items that will score in this area, at least through this month, are all unresolved ligature risks will score here. But keep in mind, environmental issues related to pediatric safety, geriatric safety, excessive clutter, all can score within this safe and functional environment standard. Here, we encourage your organization to conduct targeted risk assessments. Joint Commission does not define what a safe and functional environment is. In the absence of a clear definition, conducting a risk assessment and working on reducing or eliminating things that create the highest risk can be greatly beneficial to your organization, not only from a patient safety or environmental safety perspective, but also from a survey perspective. Let's talk a few minutes about assessing and reducing and mitigating risk. Assessing and mitigating risk allows organizations to prioritize your work. It allows us to measure the degree and scope of potential harm or consequence. These words should sound familiar to you, as it's the principle by which the SAFER matrix was developed. This assessment and mitigation of risk document then becomes your organization's mitigation plan. Make certain that this document is written and that you keep it up to date to show the progress made within your organization. Here is a sample. This risk assessment tool is designed to plot potential harm against likeliness of happening. Things that happen frequently and have the potential to cause greatest harm should be worked on first. And you'll see that those are the areas that are noted in red. So almost certainly this event will happen is on the likelihood column, and then catastrophic outcome or death on the harm category. Using your risk assessment, prioritize areas that create the greatest risk. Consider using the Band-Aid approach as temporary solutions for large projects. Create an action plan and timeline associated with those areas that create the highest risk within your organization, and keep track of your progress. Surveyors will repeatedly ask in your organization if you have completed a risk assessment. Use is not limited to environmental concerns. The risk assessment process can also be used to help you determine the risk associated with various clinical care processes also. So here's an example of a risk assessment. Here, the issue is having coat hooks in a patient room on a behavioral health unit, and coat hooks in a common nurses station. Here, the consequence of having coat hooks in the patient's room on a behavioral health unit would score very highly, as opposed to having coat hooks as a ligature risk in a common nurse's station. And the likelihood of harm occurring to a patient trying to attempt suicide in a room with a coat hook on a behavioral health unit would be much greater than the potential for harm associated with a coat hook in a common nurse's station. Our last segment today is on survey outcomes. There are 4 important categories that we need to talk about today: accredited, accredited with follow-up survey, preliminary denial of accreditation, and immediate threat to health and safety. Let's start with the good news first. Your organization undergoes survey, and the final decision regarding your organization is that you're accredited. We encourage you to do the happy dance. Celebrate within your organization, reward and recognize folks who contributed to the great outcome, particularly frontline staff that may have been questioned or had the chance to be interviewed by one of the surveyors, as this is a great accomplishment. Keep in mind this year, any organization that receives a status of accredited, all of your findings will require an evidence of standards submission. All evidence of standards compliance are due now within 60 days. Gone are the days of having opportunities for improvement versus requirements for improvement, and gone are the days of whether your evidence of standards compliance needed to be submitted within 45 days or 60 days. Joint Commission has aligned all of that to be 60 days, which makes it much easier to manage as an organization, and all findings now require evidence of standards compliance submission. Follow the Joint Commission format, the online submission form. It's a very easy process, and if you do struggle with it, you can certainly reach out to your accreditation account representative for assistance. Accreditation with follow-up survey occurs when Joint Commission looks at the findings from your survey and identifies several things. Either the organization has findings that are scoring in those very high-risk categories, or the organization has what Joint Commission will refer to as repeat findings. Repeat findings are exactly that. They're repeat findings from your last accreditation survey. Joint Commission's position around repeat findings is related to the fact that if you had those findings 3 years ago, you at that point in time needed to submit evidence of standards compliance, and in most cases had to also submit measures of success indicating that the organization had achieved greater than 90% compliance over a 4-month period of time, which in performance improvement terminology, that would be translated to the organization has found a way to hardwire the good practices within their organization. However, Joint Commission has now come back into that organization and found those same types of findings. Those repeat findings will cross-score between the leadership chapter and the actual topic or the standard of origination. So failure to show sustained compliance will advance the organization to preliminary denial of accreditation if you're not successful with your accreditation follow-up survey. Your follow-up survey typically occurs within 6 months. It is focused on those areas where the organization had difficulties or where there were requirements for improvement. And the purpose is truly to come back into the organization and ensure that there is sustained compliance. Should your organization not be successful on the accreditation with follow-up survey, that would lead to the advancement of the organization to preliminary denial of accreditation. Preliminary denial of accreditation can be triggered automatically based off of the number of repeat findings, trends in the findings of the surveyors, and what we would refer to as pervasive issues. So if they were to come in and find that the organization had not conducted any fire drills and had not conducted any inspections or maintenance of their firefighting equipment, that would be a trend, and that would be a pervasive issue that would put all patients at risk. Should your organization receive preliminary denial of accreditation, your plan of correction is due to Joint Commission in 10 days. Please note, this is a plan of correction and not evidence of standards compliance. Joint Commission recognizes that it would be impossible for an organization to truly come back into compliance with those standards within 10 days. So they are willing, and they have worked with CMS, and they are permitted to accept a plan for correction, which is due in 10 days. These organizations will undergo a resurvey within 60 days of their initial accreditation survey. Again, the purpose is to ensure that the plan of correction has been implemented. So you'll submit your plan in 10 days, and then over the course of the next 60 days, you'll be revisited to make certain that you have moved forward and implemented your plan of correction. And again, to make certain that the organization is in full compliance with all of the requirements. This survey is also focused on those findings from your original survey. Preliminary denial of accreditation, again, this process also includes active ongoing communication with Joint Commission leaders and organization leadership. Again, this is where Joint Commission wants to partner with your organization. If your survey is successful, your organization will be moved to accreditation with follow-up survey decision. Your accreditation with follow-up survey will occur in about 4 months, which is a total of 6 months from your original survey. In addition, your organization must then actively participate in an intracycle monitoring. So currently, Joint Commission allows organizations to select whether they want to attest that they did their intracycle monitoring process and are working on the problems that they identified, but are not interested or not willing to share those findings with the Joint Commission. In this case, you would have to actively participate through Joint Commission resources in the intracycle monitoring process. And last but not least, your triennial survey would be moved earlier into the accreditation cycle. So an accreditation cycle, as everyone knows, is typically 36 months. Organizations that have recovered from a preliminary denial of accreditation are often surveyed earlier, closer to the 18-month to 33-month range. Should that accreditation cycle result in preliminary denial of accreditation again, the organization is placed directly in denial of accreditation. So a lot at stake. Preliminary denial of accreditation is oftentimes also associated with immediate threat to health and safety findings. These are key types of events and situations that trigger an immediate call to Joint Commission Central Office and conversation with the CEO of the organization or the highest ranking official on site at the organization. If your accreditation organization declares an immediate threat to health and safety, when talking with Central Office and the CEO, they will disclose to those persons what the finding is related to. So for instance, if the finding was related to ligature risks in, let's say, the emergency room, this would be disclosed. The organization must immediately correct the situation prior to the surveyors leaving for the day. Again, they've declared this to be an immediate threat to health and safety. So we need to make certain that we immediately come up with a corrective action. Keep in mind that that corrective action may not be your final fix, but it might be the fix that you need to implement in order to mitigate that risk. Your immediate actions will need to be provided to your team leader in writing prior to their leaving the organization for the day and will need to be shared with central office. The last category that we don't like to talk about, but we are certain has occurred, we know has occurred across the country, and that's denial of accreditation. Denial of accreditation is held back by Joint Commission for those cases where all appeals and all opportunities to show sustained compliance have been exhausted within the organization. Closing tips for success. Make certain that you use regulations and standards as the foundation for patient safety. Create a multidisciplinary team to focus on identification of barriers, suggestions for moving barriers, and timeframes for completion. Recognize employees who identify and report compliance issues. As we only have so many eyes and ears, we have to rely on frontline staff to identify those areas of concern for us. Listed here are a few of the sources of information that we utilize to develop today's presentation. At this time, I want to thank you for your time today. We hope that the information will be useful to you and your organization. Should your organization be interested in more information, please contact your Interlear representative. And thank you so much for your time today.